everybody's so quiet, I'm going to call the meeting to order. Take advantage of an opportunity. Erica, would you call the roll?
Mr. Furman,
Here.
Dr. Klotz, Ms. Schulman, Dr. Hans,
Here.
Mr. Rubin,
Here.
Mrs. Summers,
Here.
Dr. Taub,
Here.
Ms. Logan, Mrs. Respecki,
Here.
Ms. Newman,
Here.
Dr. Arrington,
Here.
Mr. Landsman.
Thank you. The next item on our agenda is our first opportunity for public comment. As far as I know, no one signed in. Is there anyone who would like
operational since July of 2010. Our agency's been considered trauma-informed before that, but we actively partnered with the CMH initiative when it came out in 2011. We were really excited to see that because we recognize that trauma affects the children that we serve in all of our programs and the people that we serve from all age ranges throughout the different programs at OFS. In particular, in the program that I work with, I would say that easily 90% of the children have been affected by trauma in some ways. Now, some of them have had traumatic experiences. Not all are traumatized all the time due to resiliency factors, which I'll mention a little bit later. But we began in partnership with CMH initiative, agency-wide training and assessment following the work group establishment. We developed individualized plans for all of our offices and all of our departments. And they included some things that appear kind of simple, but really affect how people feel when they enter an agency. Changes to our waiting areas, the color of the paint, the choice of decorative items in the waiting areas, access to restrooms, simple fixes to ensure privacy. We do, for example, a lot of drug screening in some of our programs. And so we made, we allowed, we're not a medical facility, so we don't have that little aluminum door that you put your urine sample in. So we provide everybody with brown paper bags so they have some discretion as they walk through the waiting room. We changed our meeting rooms, our public spaces, our hallways, and gradually we have a plan to do all of our offices to, again, to paint colors that are more soothing and calming for anybody who comes into our offices. We did a complete revision of our intake process for the kids and families who come to us. Our intake can be very long and sometimes take anywhere from 2 to 3 hours. It's very intensive. There's a lot covered. So we provide snacks and beverages, and we make sure that they take breaks. And if they bring other children, we try to provide childcare and breaks for those children as well, because we are really asking a lot of those families that come to us for an intake. So we assessed all those, we implemented those, and we continue to do that. We created a secondary traumatic stress support group for all of the staff within our agency, and we've recently opened it to other non-agency employees who work with this population who's affected by trauma, including DHS staff, for example, so that if they want to come and get some support for the secondary trauma that they experience, hearing these stories day after day, they have a safe place to come to. We do ongoing trauma training from the very beginning when we first hire someone. Part of it, it's included in the very beginning of our onboarding process. The first thing we do is we require that all staff, all clinical staff, complete the University of South Carolina Medical School online 10-hour training on trauma-focused cognitive behavioral therapy. It's an excellent online training, but it just serves for us as a baseline because we want to follow that up with more evidence-based training. We have an internal agency trauma-informed awareness training that any staff who comes in, whether they're admin staff or in a different department, they all go through that. We have we show them the CMH training that was provided through the grant, and then we also do all clinical staff participate in different cohorts of the trauma-focused cognitive behavioral therapy training that's been sponsored by DCH, I guess it's DCHH now, and also sponsored and supported by CMH here. Nicole has been a driving force for that and a strong supporter of both ourselves and Easter Seals being able to send staff and have staff specifically trained and then certified. So far we participated in 5 different cohorts and soon to be 6. It's an intense training program. There's a year commitment on the part of staff, and it requires ongoing support and supervision as well, so it's not over when it's over. We have several staff who have become nationally certified after they've become state certified, so we're really happy to be able to provide that level of care to our consumers. There are regular coaching and supervision calls. There's regular group supervision that we sponsor at our agency. We also did what was called resource parent community training, where we've conducted anywhere from 2, 4, or 8-hour workshops in the community, at our offices, at such places children's brain development so that they better recognize it and understand it. And of course, sometimes they recognize that they themselves underwent trauma as a child and have a better understanding of why they have some of the problems that they have as adults now. So it's been tremendous support and a tremendous impact on the children we serve to be able to do this secondary level of training. We are involved now in our phase 2 implementation of our own trauma-informed process. We have an agency work group. We reviewed the ACEs study. We have applied that to our adult services and are looking at the effect of adult trauma on the parents of the children we serve with trauma, because we know that those tie into each other. We've done a thorough training of all staff. We have representatives from all of our programs. We are doing walkthroughs as we speak. We did them previously, and we're revisiting again, where we have people come to different departments and act as if they're undergoing an actual intake, and then give us feedback on how it felt to them, what was working, what wasn't working, what felt comfortable, and maybe what didn't feel comfortable. And then we've done an agency-wide organizational secondary traumatic stress assessment. That was very revealing. I participated along with Easter SEALs and staff from here in a statewide pilot cohort to look at secondary traumatic stress. We completed different what are called PDSAs, which are work plans to effect change. And everybody in my agency has completed that questionnaire. It pointed out to us things we thought people knew that we provided supports in regarding secondary traumatic stress, and things that they don't know. And so it points us to new training that we're going to be doing for all staff, including both at onboarding and ongoing. So that's something that we learned through that process. We're also looking, as I said, we're exploring adults who've suffered trauma and who are now the parents of children who've suffered trauma, because we also recognize that the medical impact this has on health issues, especially for adults. It shows up in different things in all areas, all medical areas, heart disease, blood pressure kinds of issues, weight, cigarette smoking, substance use, all these areas. So we're trying to blend that into everything we do so that we are very holistic in our approach to trauma. So next steps are probably the most challenging: to review the findings and keep the momentum going, initiate new work plans for each department and implement them. And then we'll be doing periodic reviews on a regular basis of where we're at with each work plan. Really trying to make this a sustainable effort, not just a once in every 3-year type thing. So our work group will continue ongoing. We also are working and training on resiliency, because we recognize that a lot of people survive trauma events because of resiliency skills that they have, or resiliency experiences people they had in their life that helped them. So we want to build that into our clinical work. Challenges are taking this from an initiative to just natural practice, so that it's just embedded in everything we do. And as new people come on board, we just teach them that that's who we are as an agency, that we are trauma informed, and this is what it means. So it's an ongoing operational effort that includes individual and team supervision, ongoing participation in learning and training, and also ongoing review of the literature, continuing to find what are some of the evidence-based practices and continuing to participate in those trainings as we are supported in that, especially by CMH, which we are very appreciative of. So thank you.
My name is Amy Nima. I'm the Director of Programs at Common Ground. We provide crisis services and early homeless programs. So our journey around trauma-informed care also started around 2011, when we had several
do with it. And it's really good to hear that Common Ground is taking the lead nationally. So I want to commend you for the work that you're doing. Thank you so much. It is so important.
Other questions or comments? Very informative. Thank you very much for the presentation.
Thank you.
The next item is the presentation on Google.
Good afternoon. My name is Peter Mott. I'm the Systems Engineer and the Security Officer for Oakland County. And thank you, Darlene, for inviting me to this presentation. This is just an update for Google and their compliance with HIPAA security. OCCMHA doesn't use like the consumer grade of email. We use an enterprise-based product that we have with them. It's Google Enterprise Apps for Business. And this allows us to be the master of the domain for @OCCMHA.org and everything and every piece of data that's within it. This also allows us with this arrangement to have a HIPAA Business Associate Agreement with Google on file, which is required by law with the HIPAA High-Tech Act. We also use one of their other products for HIPAA compliance, and that is now called Google Apps Message Encryption. This allows us to have encrypted email between any member of our staff, and it also allows us to securely communicate information between our email servers at Google and with any of the provider community, as they also use a product from Zix Corporation, so we can exchange electronic encrypted email through Google. We can also communicate securely with smaller providers who don't have that kind of resource. So like in Arab Building, for example, a smaller agency, we can send them encrypted email and then they come and pick it up at a portal. So we can communicate securely with email with anybody on the planet that has an email address. Being the master of the domain at CMH, that means that our entity is completely separate from all other entities that are Google customers or self-contained. So only OCCMHA staff can see what's in our domain. Google doesn't even have access to the encrypted email archives. It's encrypted both in transmission when we're transmitting an email, and it's encrypted at rest when it's sitting on a disk in a server farm somewhere. At any time, we can terminate any user, and we can turn off any services, so we can selectively determine what Google applications or services a person has. So we have total control over what people get and what they don't get. Google does not collect or advertise in an enterprise environment, so we don't have the banner ads and they're collecting or tracking the information that we're transmitting. Because some people were saying that, you know, the commercial grade Gmail does a lot of that, but an enterprise product does not. However, we do have access to that data for our own purposes, so we can data mine. So if we're doing a Google site, for example, we can data mine who's accessing it, from where, what parts of the site were most popular. So we have the same access to the tools, but we control all the access to the information. As far as standards go, for HIPAA, Google actually is at a much, much higher standard. These are the industry certified gold level certifications, ones that are used by the federal government, Department of Justice and such. So these standards are much, much higher auditing security standards than HIPAA. And so using Google Enterprise actually puts us at a higher level of security than if we were able to do this ourselves, because we could not afford to or have the size of business to meet these higher standards for security. As far as government and law enforcement and subpoenas would come, if they did come to Google, Google would automatically forward them to us. So our business associate agreement is such that it is our data and we are the ones that would sit there and answer the subpoena, not Google. If the federal government comes to Google and subpoenas them, they do actually post who and what was asked for them, and that's published on their website. So they're very transparent about if the federal government's coming in and asking about an enterprise, you know, who did that and what was released. With all the security that Google has, security still is everyone's job, and it's also our job in the way that we use the tools. So when we outsourced email, there were many reasons for doing it, you know, enhanced security, but it didn't eliminate our responsibility, you know, towards of the other tools that we use is Google Enterprise Drive, and this allows us to store our documents so that we can gain access to them outside the network on our phones, PDAs, and tablets. Some of the advantages over traditional Microsoft products that it gives us is, one, being able to access our information from anywhere that we're at on any kind of device, but also this thing about Google has that ownership. Only the owner can delete the file. You can share it with other people, they can comment on it, they can edit on it, but no one can delete your file but you. And so that it gives an assurance towards people. All access to that file, who touched it, who looked at it, who read it, who opened it, it's all logged in the system so we can see who touched the file. It has version control, so if you are sharing it, every single change that was made to the document is documented with the time and date stamp to who changed it. So it gives us a higher level of security and also the ability to collaborate better with more people as well. So it's definitely far better than carrying your data around on a USB stick, which is always a big concern because what if you lose it, what if you forget it and leave it in a machine in a hotel or somewhere. So having it on drive, we can actually control it better than we could with the Microsoft product, better than if the user's just carrying the information around on a thumb drive. Now some of the other things is that we liked about Google that are built in and are free with the purchase is that we have mobile device security built in the box in the product. Meaning that anybody that has a cell phone or a tablet, if it's CMH's or if it's their bring your own device, they're bringing their own device, whenever they join that to our domain, I have to approve it as a systems administrator. So same thing applies. If I see somebody that's applying and trying to register a phone to my network, I get an email. They say, hey, did you buy a new iPhone? I know it's not somebody in China that's trying to link up to my network with a new phone, because they're like, oh yeah, how did you know I just bought a new phone? Because I saw when you connected it to the network, and I have to authorize that phone, and it showed me your phone number and your serial ID. The other nice things about that is if you call me and you tell me that you've lost your phone, I can send out a command and I can remote wipe your device so that your data and my data and everybody's data is encrypted off the device and turns it back to factory new. We can enforce security using pins. So just like the computer, the phone should time out and lock. So in case you leave it somewhere or someone steals it from you, they can't have access to our information or your information. And I can even encrypt the device itself, because the cell phone really is an identity theft dream because it has all of that information on it. Most of the time it's like security is circumvented by hitting the phone with a hammer and taking the chip out and reading the information on it. So you can actually encrypt the device as well, because they're more likely to want the information on the phone than the phone itself. Chromebooks are another tool, as many of you have Chromebooks, because it's a laptop-like device, but it's a fraction of the cost, and it doesn't store any data on it. So you hear a lot of horror stories about laptop gets stolen out of a car at an airport with medical records on it. Chromebooks don't actually store anything on them, and the little fragments that they do are encrypted, and that's all built into it. So a Chromebook is a very efficient, very cheap, and easy way to have access to the information at any time. Because basically a Chromebook is a Chrome browser in a box. And everything on that device can be, again, remotely managed and configured. Features can be turned on and turned off. One of the big reasons that we started looking, we've been on Google Enterprise Apps since 2009, and one of the big reasons is, management was like, email's like electricity. If we don't have email, we might as well go home because we can't communicate, we can't collaborate. So one of the big things was we wanted to have fault tolerance or uptime in the 9s to 99.9%. And Google can do that for us because it's not just one server sitting on a rack in one data center. It's multiple servers and multiple data centers spread across the country, so that if California falls into the ocean in a giant earthquake, I still have my data replicated to New York or some other Google site, so I don't have to worry. Or if this physical site, were to burn to the ground, we still have all our email and collaboration from another site at the RCC or any other location. So we're not, a natural disaster isn't going to take us out. Some of the other tools that they give us is passwords are weak. Most people use bad passwords as the first problem, but passwords can be, cracked over a period of time. So many companies are going towards expensive solutions called two-factor, something plus something you possess. So for example, Google can be set up right out of the box with no additional cost to automatically send you a text message when you log onto a computer it doesn't recognize, so that you would log in with a username, a password, functional services that can be added in that are enhancements. One of them is called Google Vault. Some companies and some of the provider agencies haven't outsourced their email because they had anxiety over tapes and email archives. I've got to keep everything forever, and I want to sleep with it under my bed because if I get a subpoena, 9 years from now, I want to be able to dig that tape up and pull that email back. Well, Google Vault is a service that basically keeps every email ever sent or received for 2 to 10 years in a separate read-only archive. It's a service that you can purchase, but it saves you a huge cost, a huge burden if you want to use that, for searching for emails. So Hillary Clinton could have used this for searching all those emails that you were on Google Vault. The other things that we have is we have a password sync tool. Our users have probably 10 to 12 different passwords and user IDs just within CMH alone. So this is the password sync tool is when they change their Windows password on their computer here, which they're required to by HIPAA every 90 days, they'll synchronize that same HIPAA secure password over into their Google Enterprise email. So it reduces the trouble calls for users, gives us better compliance with longer, tougher, more difficult passwords to have. The other big thing that was huge for us was the amount of spam that we used to get in our inbox. It was overloading the server, it was overloading people's mailboxes, and just wasting their time deleting it. Now with Google, 95% of that email ends up in the spam folder, and it's a non-issue. So we have a really good product that takes the spam out of our email boxes and protects us from viruses and malicious things that would have hit us in our email server. No more patches. We don't have to patch the system. Google handles all of that, and then they have a dedicated team of security professionals. And then the other things that it gives us are Google secure sites. So we have the ability to create these sites that can be seen from outside the organization, or they can be restricted to authorized users. So for example, we have an OCCMHA board member site, and also a provider work group site. So we're working on a site that would be specific to all things providers, all the information and resources that would be specific to them to help do business with us. So we can create those kind of sites with the product. So why did we pick Google back in 2009 when we started looking at it? Cost and complexity of the Microsoft product. When we started looking at it, especially when we wanted to have that 99.9% uptime, being able to have duplicate servers in multiple locations, it was extremely expensive. So with that, we could experience with the Google product no downtime. The email backup is taken for us. The archiving of email, one, we don't have to do it because people have plenty of space. And if we want to archive email up to 10 years, Google can do it for us. The antivirus and anti-spam is top notch. And everybody can access their email from any device that they choose. So it's not just a Microsoft Outlook. We can use any different product that we want, a phone, a PDA, a tablet, an iPhone, doesn't matter. So everyone's always on the same version. That's huge for us, so that from a training standpoint, what you see in the office is what you see at home. It looks identical. When Google does updates, it looks identical. Come to work on Monday, everybody's working on the same version and the same product, so it cuts down the support tickets. Changes roll out a little bit slower. Google will implement new features. They give us a heads up on what's coming. There's small changes. So it's not like coming into, well, if you had Windows 8 when you bought a new computer and you brought it home and it's like, what is this? I don't even know how to turn it on. The changes are gradual and they're small, so it's not a shock to somebody when they come into work one day and go, oh, look, they changed the whole way that the product operates. So that helps, again, for trouble call tickets and training. And we didn't have to hire more technical staff to support the Microsoft product. So, any questions?
Apparently you did a perfect job of explaining everything. No
Okay.
questions. Appreciate the information very much. Do you have
I do.
Sid?
Peter,
Yes.
thank you very much for that, presentation. A couple questions, and these may be operational questions as opposed to technical questions. Each board of director gets in their board of directors packet a lot of information about newsletters that were published or news media. Is there a way for us to get them more frequently and less voluminous this at one time, because I, for one, I like to read them, but it's difficult to read a big stack of those interesting articles. And if I could just tap into them, as I go along and read a couple a day or whatever to catch up. And as I say, that may be an operational question as opposed to a technical.
Half and half. Operationally speaking, yeah, we would need to get the information to you, but technically speaking, your board member site would be the perfect vehicle for that, because we could post the information possibly more frequently, and then you would have access to it.
Right. Well, that would be good. And that's basically the question I had.
All right, thank you.
Well, Darlene?
submit 2 audits to OCCMHA, to the quality management team, for systemic review twice a year. They would audit the other protocols kind of based on their knowledge of their own individual agency, maybe things that they wanted to check and see how they were doing, or maybe processes or practices that they may have wanted to improve. They would then submit quarterly and year-end reports to this organization so that we would monitor and see how they were doing. The other piece of that would be the specialist review function, whereas we have authorization decision guidelines set. We're typically people that exhibit a certain level of need intensity, typically would require services in a generalized kind of amount, scope, and duration. But recognizing that not everyone will fit that bill, and sometimes people need services that are above or below what those general guidelines are, the expectation was that there's always an exception process so that people can get everything and anything that they might need and that they're entitled to. This is called the specialist review process, and it was being conducted throughout the network by people that the core providers would choose that they believed had the experience and the credentials to help to make those decisions.
as the utilization review function, I think we kind of touched on this. One of the things we really hope to improve is that coordination of care directly with the hospitals. We hold the hospital contracts here. So working through a third party, via Common Ground was a little bit of a distance that we would like to close. So we're hoping that that can really move us toward improved discharge planning. Our providers do a pretty fair job of discharge planning access has been completely separate from our other utilization review process. Currently, we have a state facility liaison, which is Adam Hamilton. He will continue to have some role in having a relationship with state facility leadership. But we know that once someone is admitted to a state facility, there's also a tremendous need to follow along in that care as well. Perhaps more so, since it is truly our most restrictive type of setting. Especially for admissions to Hawthorne, which is the only children's state facility. We do have access to Hawthorne as an acute stay, which means in substitution for a community hospital. But that requires that we have someone doing that active utilization review for those stays as well. What we're looking at is the opportunity to become more efficient in this area and kind of shift some of the functions that Adam was performing to the utilization review OCCMHA staff to actively be involved in reviewing and monitoring those cases as well.
So, budget neutrality is an important consideration through this process. For the UM function, prior to the transition, the annual cost was $695,130. After the transition, we're looking at an annual cost of $686,000. So that's a savings of almost $10,000 per year. For the UR function, the annual cost prior to the transition was $342,219. Currently $285,382, so that's a savings of almost $60,000 per year. So in essence, the transition is budget neutral. However, the strategic and software savings include more consistent authorization of service and reduced travel and meeting time. So all the things that we've just been listening to.
Are there any questions for the panel? Betty?
I just want to make sure I understood. You said the clinical justification will be provided for any requests outside normal protocol. Is there any issue about turnaround time for that, for the client or patient?
We have established a specialist review protocol that takes into account the turnaround time between when we receive the request and how long we have to respond. So we have 2 business days. The staff will go in and review every request when it comes in, but ultimately we do have 2 business days to respond, and that allows sufficient time for
they're making decisions about services that can be provided for people coming into Common Ground?
No, they're making determinations if someone is in, they're developing their plan, and we have the authorization decision guidelines, which typically says that if this is the set of needs that you're presenting, that typically your needs can be met by service authorizations within this scope, and that's what the authorization decision guidelines offer. However, there are times when someone says, I could benefit more from service A. And so then there's a clinical justification done. The provider agrees through the person-centered planning process. Says, yes, we agree that you could benefit from more of service A for 3 months, 6 months, whatever the time period may be. And then they submit that request then to the PIHP. And what that does is it's called conflict-free case management, which the MDHHS has been throwing around a lot. And essentially, they don't want people to self-refer. And so by using the authorization decision guidelines, essentially the PIHP has pre-approved a certain set of services and supports in a certain amount, scope, and duration. And so that kind of allows the decisions about those services and supports to rest through the person-centered planning process, and we're not involving or delaying that process at all. But when someone has needs that exceed that or fall outside of that, the provider cannot then just essentially approve their own services. So then that needs to get kicked up to the PIHP for review and approval or denial.
The PIHP being those 8 people?
Yes.
Okay. And so you also mentioned a little bit about if someone's hospitalized, this team would be looking at anybody who's hospitalized to help them with transitioning out of being hospitalized. Is that what you said?
Well, yeah, kind of the way to distinguish between the two functions is that utilization management is primarily about services provided on an outpatient basis. That's what our community providers are providing and being overseen and tracked through utilization management. Utilization review is the same function that we've always had to provide for people who are inpatient. So that function, yes, is tracking length of stay, appropriate treatment, transition, and discharge planning. It's essentially the same function that we have had in place all along. It has shifted kind of in whole to OCCMHA.
And so you're doing this for all of the core provider agencies?
Yes.
Anyone?
And actually for individuals who are not even necessarily served by our provider network, as the PIHP, we have to manage the stays for all Medicaid inpatients. So even if they're being served through their Medicaid health plan, Molina, United, whomever that might be, we still have to do both the initial authorization and the ongoing continued stay review.
Well, that brings up an interesting question. What's your percentage of people who are not receiving services through CMH who you are looking at, analyzing, whatever? How many people are you?
I'd have to pull up the dashboard to take a look at it.
It's probably too soon to even ask that question, but that's something.
Well, no, because we've had the data all along as Common Ground's function. So we kind of slice up the pie and take a look at who we're authorizing, who are primarily maybe the Health of Michigan. We can break it out by level of care, whether they're in our system or not, and take a look at how many of those folks are outside of our system that are coming to us for inpatient. Because that also includes anyone who's currently uninsured, as well as the other Medicaid plans.
So you are taking people who are uninsured.
Crisis and inpatient care, yes, remain intact for people who are uninsured.
And does your group, MAHA, do you look at the wait list? Is that part of your?
My team manages the wait list, and so we take a look at it on a daily basis to make sure that the people that were added to the wait list were appropriate for the list. We do a double check to make sure that any needed referrals were made. So for instance, if someone disclosed that they were seeking mental health services, but perhaps they also had a substance use disorder, we ensure that they were referred to an outpatient substance use provider and or PACE.
there are 10 PIHPs throughout the state. And utilization management, utilization review is a function of each PIHP. Oakland was the only PIHP that actually delegated those functions out, and we delegated it out to multiple providers. One of the things that the state is trying to get us to do is eliminate the different layers of administration, and then also eliminate the inconsistencies. So having several providers perform that function, it produces somewhat inconsistency. It also makes it difficult for us to receive all the data and have the control. So again, we were the only PIHP that actually delegated those functions out. So it's not new. The only thing is new is that we're consolidating it. We're doing it in-house, and it will allow us to provide a more consistent overall management of the program. It also put our providers in a situation that they don't have to worry about having a conflict in the management of the care. Now they have a third party that they can actually go to that can justify and make those decisions in which they would not have to make those decisions directly with the people that they're serving. So it really helps us with conflict-free management. It helps us with consistency, and it helps to manage costs.
Sid?
Yeah, Willie kind of answered some of my questions that I wanted to have, and it wasn't planned this way, but thank you. And also thank you for undertaking this major project, all of you. But my question is to Steve. Steve, you threw out two numbers. One was a $10,000 savings. And what was that for again?
That was for the utilization management function.
Okay, that's what I thought. And the other 60,000. You are. So, having said that, and recognizing that this year isn't even complete, and you say that there is a savings, and the reason I'm really focusing in on this is because we all know the biggest challenge that everybody faces in this whole industry is the challenge of doing more with less money. So one of the undertakings, and as Willie said, it eliminates duplication. So there's got to be a savings in cost there. And I'm concerned, and my interest is making sure that more money goes to the people we serve and the programs we serve during this consolidation period. So is there a systemic savings that you see, or has somebody projected out that this would save? It's not even an actual savings, because if we're getting less money, we're closing a gap, basically. To be more simplistic about it, we're closing a shortfall gap that we have, okay, that we have to, pare down to our core providers. So is there any indication of some long-term savings, and any amounts?
Well, the numbers that I gave you are an annualized savings amount. So the $10,000 savings on the UM side would be a $10,000 savings each year going forward. On the other side of UR, that's a $60,000 savings each year going forward.
So those are systemic savings.
Correct.
Recognizing that you don't have the program fully operational now.
Right, and so what we're doing is we're transferring budget dollars from the core provider budgets into the centralized CMH budget in a partial amount for this current year, and then full annual amount going forward.
And that would be $70,000 a year going forward?
That's actually the reduction in cost. The transfer of the budget is the full cost of the program. Right. So when I said that the annual cost, for example, for UM prior to the transition was $695,000.
I see. So you're shifting
that
the
money
other
is
part.
coming-
You're shifting the other part.
Right.
So that will. Okay, I
Does that make
understand that.
sense?
Yes.
And in fact, right, so the OCCMHA centralized budget is only $686,
Yeah.
which is less than the amount when part of the core provider budget.
Okay, that makes sense. Yes. Thank you.
taken, I want to make sure that the board understands. One, the dollar savings that was mentioned as it relates to the 10,000 and 60,000 is very minimal in compared to the savings as it relates to having the consistency across the board. Any dollars that are actually quote unquote saved are not really saved budget-wide. It's just that the dollars are shifted so that we can use those dollars to meet the needs of some of the other individuals. For example, if there's any type of savings that is determined by the UOER process and in which dollars are actually being saved from the process, then that allows us to use those dollars in other areas. Saying savings sometimes is dangerous because then people say savings, that means you can cut. And in this situation, it's not really a savings. It is a shift and putting ourselves in a position that we can provide more service to the people that we serve and make some of those hard decisions as relates to making sure that adequate care is being applied consistency. Because whenever you don't have consistent, adequate care, that means someone else suffers because those dollars cannot be used in other areas. So this is a very important step in managing care versus just managing providers. But we're trying to manage care more effectively, which is dictated in our requirement of being a PHP.
Johnny?
Does the UMUR, do people with developmental disabilities go through Common Ground for services as well as everyone else?
Mm-hmm.
And so you are also looking at that data?
Other questions, comments?
I
10 PHPs in the state, the majority of the PHPs, if not all of them, are actually in the process of building reserves. Typically in times of uncertainty, people begin to build reserves. Oakland is one of the exceptions in which we're actually spending reserves during that time. So there is an effort to try to be budget neutral. So I just wanted to make sure the board understood that the $5 million is not a reduction, additional reduction. It is eliminating the use of reserves and the fact that the norm right now is building reserves. We are not building reserves, but it should be noted that adding to the reserves in times of uncertainty is not a bad thing to do. Eventually, we have to at least get at budget neutral because of the severity of all the cuts. As you know, we made a decision to spend reserves. However, our goal is to become budget neutral. Simply meaning spending, our revenue and expenses basically has to balance.
Yes, thank you for that clarification. In terms of the autism benefit, I'm not going to go into any detail on updates because our next item is autism benefit, so we'll go into more depth there. And then for the home and community-based setting item, I just wanted to let everybody know that we still have not received the survey results. Last month, I had indicated that we were expecting to get them in late June. We have not received them yet. So once we do receive them, and we're just in the early stages of July, so hopefully that'll be very soon, we will share that information, and then the protocols related to the transition will start to develop those internally. And we are having monthly internal meetings at this point, monthly, to plan for the home and community-based setting transition. If we need to increase the frequency of those meetings, then we can certainly do that once we get this information.
Questions, comments? I just have one comment. I would really encourage some sort of follow-up for fiscal year 2016 regarding the transition, only because it's possible that that's something we're going to face again, and it might really be worthwhile to have some guidelines or process in place in case we needed to monitor that or provide some oversight to that for the longer haul. I do know some of the families that have been involved, and I think it's probably gone as well as something this disruptive can. I mean, it is pulling the rug out from under a lot of people, and there are still some unsettled feelings that may not fully come to light for a little while longer too. So I hope we do keep an eye on that in some way. Maybe increase some rights monitoring or do something of that nature to make sure that people are, and their supporters, their allies, their families, whoever is important in their lives, are being heard and feeling like they're being heard. Just a comment. Okay.
I had a question. I didn't know whether I should hold it until Kathy did her presentation. But the question I had, when we did the cuts in 14, the board received the plans, what each provider was doing to do their reductions. We didn't get the plans this time, and I'm wondering, will we see the decisions that were made at the core level so we know what they did in terms of reduction?
For fiscal year 15, we have presented on that in the past. Are you talking about for fiscal year 16?
I don't remember seeing any plans for 15.
Early in
Kathleen presented.
Yeah.
Kathleen presented that.
Okay, then that's my oversight on that going forward.
So-
We're going to 16.
In fiscal year 16, as decisions are made, I think I can speak on both of our behalves. As decisions are made, the board will be kept apprised of.
But the other thing I really wanted to see, and I don't know if anybody considered this, is the year to year, what was done. What was done in 14, what was done in 15, and what was done in 16. And I guess the reason why that's important to me is this is the area that we get slammed on the most. People are coming here telling us this is being done, that's being done, and personally, I can't speak to it because I haven't seen the plans. I don't know
believe. So it's a new policy for CMH. I don't know who drafted it. Now, is that the policy that you are now going by for this?
I'm not sure what policy Lydia reviewed with you. I mean, she's. Oh, was it the policy related to supports for community living and people living in one supports? Okay, so that, if it is, that's unrelated. That's unrelated.
I didn't understand why, well, I guess I need to go back and review my notes, but why was that policy presented to us?
Well, that policy was presented because it was formalizing our approach to addressing situations where individuals are living alone 24/7 one-to-one supports when it's not clinically warranted. So that was to keep the board apprised of formalizing what was already sort of
always be partners with the emergency rooms, whether we have a contract with that particular hospital or not. People go to where they feel they can get the help most quickly. Sometimes it's because that's where the ambulance has taken them. So these are important partnerships. We just wanted the board to be aware that we're working on those relationships. That'll be an ongoing kind of project with those health systems. The other change we're creating, I know that you've all been familiar with JDAT. It's been around for quite some time, and that is the Jail Diversion Advisory Team. It's been a part of an Oakland County initiative for many years. We want to acknowledge all of the good things that have been accomplished there, continue those very good things, but then also expand the vision and the efforts for what that team is going to be doing going forward. As you noted in Kathleen's strategic plan, there's a whole section on the justice system and the interaction with the mental health system. So we want to take that group, we want to expand it to include the efforts that we're pursuing in terms of working with the court system. It's not just about avoiding jail, it's about what happens when you end up perhaps in the court system. We also want to work with the justice system in terms of their interaction with our hospital partners. So there will be a whole work plan that we want to bring forward for this group to engage in. As a result, we will be also bringing some new names forward to this group to kind of christen a new name and a new effort. So we will be taking that first to the JDAT team, the JDAT group, which is made up of a large number of community partners. Sheriff's Department sits on that group. We have had the opportunity to have a judge there in the past. So we want that group to be invested in kind of where this is going. So we will certainly keep you apprised of the new name, but we also want to get the new work plan in front of you as we develop that as well. The last item is to inform everyone that an email did go out to the CMH staff as well as to the Common Ground staff today, that we met with Common Ground at the end of last week to discuss the transition of the access function back from Common Ground to OCCMHA. The access function has been a couple different places over the years. It was centralized, decentralized, re-centralized. We've seen the value of having a centralized access system. I don't think anybody has questioned that. It has given us the consistency of decision making that was lacking in the past. Again, that conflict-free decision making is important as well. But as we have had to make significant changes at our front door, as we've had to define priority populations, and as we've had to manage the wait list, we've definitely noted the duplication of administrative efforts around that whole process. So the timeline for actually transitioning this function is something that we'll be working with Common Ground to negotiate and define. We certainly anticipate that to be the case by the new fiscal year. And you know, we know there are going to be multiple steps here. There is an entire communication plan that we'll have to make sure is in place so that our community partners know of that transition. We would like for it to be as seamless as possible for the community. Our plan right now is to continue to have that toll-free number understand the change and are part of any processes that need to change on their side as well. So again, this is a fairly significant change for the system, but we wanted you to be aware and ahead of time that this is where we are moving. Timelines will be out hopefully fairly soon.
I just want to add a couple comments. One, Common Ground has been very cooperative in its effort. We are working with Common Ground to have a smooth process with this transition. We're also working with Common Ground to look at different partnerships with them on some other things that they can assist us on. So I just want to make sure it's noted that Common Ground is fully working with us, fully cooperative, and we are strengthening our partnership with Common Ground and looking at other ways that we can actually invest in Common Ground in this process. Again, this is another one of those layers of administration that we're trying to allow consistency, lower costs, and become more standard with the PHPs throughout the state.
Yeah. Where will the single point of access be physically located once it's transitioned?
It will still be over at the RCC.
Other questions or comments? Darlene?
Okay, so I wanted to go back to the JDAT group and ask if that jail diversion group, do they, they're not the same thing as the group at Common Ground, are they? Because there's a group at Common Ground who work with jail diversion. They actually work with people who are in jail, and they have to meet a certain criteria and go through like a program. Is that the same thing, or?
No, that's completely separate.
So are they ever going to work collaboratively together, or?
Well, they're part of that larger effort, absolutely. I mean, they're not jail diversion, that's like the post-book.
Yes, it is, that's right. It's people who are actually in jail.
Right, and those services are provided primarily by Easter Seals, provides the mental health treatment in the jails. And then I think you're referring to the adult treatment court program that people are referred to, correct. That staff person, yes, is a Common Ground staff person, and they do sit at the table with JDAT. They're part of the team.
Okay, I just wanted to make sure because it's like two different things, but
it's a lot of different things.
Yeah. And I had the same question that Steve did about where, and so I kind of figured it would still be at Common Ground. Now, when this occurs, will you be using the same staff that do access now? Will you be doing it differently, or how is that going to work?
We have some different expectations around the function as it transitions over. So there will be postings. The current staff will be just like the UR staff and the UM staff. Those positions will be posted. They will have the opportunity to apply, and then we'll build
dashboard does provide us an opportunity to just have a snapshot of just even initially looking at how many children we're serving with the autism benefit, the services that they're receiving, even an opportunity for all of our core providers to take a look at it, and they can pull up information that they need. I mean, I could go into detail about this, but I could probably bore you a little bit. But we're really excited about this, and I'm excited about some of the changes yet, if you don't mind. So going into a little bit more information about the dashboard, we're looking at the dashboard to reflect some of the evidence-based practice that the applied behavioral analysis services provide. So we're looking at the frequency of supervision. So just to give you an idea, for every 10 hours of ABA therapy a child receives, there should be 1 hour of supervision provided by a BCBA. So this makes sure that the technicians are receiving the necessary supervision that they need, and that the child is receiving therapy that benefits them and it is appropriate for them. We're also looking at the frequency of family training. This is really something that the state is pushing. They really want families receiving training about ABA, how they can implement it in the home, strategies that they can use at home to provide the necessary skills and support to the family. So some of the things we'd like to add to the dashboard, and actually we're in the process of doing, is because part of ABA therapy, for children with the autism diagnosis, there are some behavioral issues and concerns. So we're looking at seeing the number of emergency room visits, emergency assessments at Common Ground, because the idea is when they're in ABA therapy that these would decrease or eventually they would end. So again, we're hoping to see a decrease over time. It measures the efficacy, thank you, of ABA
kids, I had a chance to spend time with some families, and they do have relatively young children that have been diagnosed with autism. The prevalence is, they're saying anywhere between 18 and 28% of kids with Down syndrome will also be diagnosed with autism. Have we had any?
Not that we are aware of. I mean, that's something we could definitely look at, but it's nothing that's happening on a frequent enough basis that we're saying, oh, hey, look at this. So if it's happened, it's been, one or two maybe, but that's something we could definitely look into. That's the first thing.
Dr. Rosen seems quite anxious to make a comment.
We know that people with serious mental disorders frequently have co-occurring conditions. That's true for both adults and children. So as we begin to understand autism better, it's really a new understanding of what's happening with children and young children. Is that very often there will be co-occurring illnesses like Downs, or obsessive compulsive disorder, or depression, or perhaps bipolar disorders. This is an emerging field. As we begin to understand and evaluate these people better and track what's going on, I think we'll have more answers to the kind of questions that we all have.
So we've certainly been supporting people that have autism along with other co-occurring kinds of diagnoses. I can't specifically say if Down syndrome is on that list or not, but it's certainly something we could look at and easily find an answer to.
It may be something that's just emerging, very slowly at this point, and it could be with the expansion, there might be a different group of people who present also to the system.
I suspect that with the expansion, we're going to see a very diverse group. Because, the 0 to 6, you're still learning who the kid even is, and there's a lot more information and a lot more nuances when you're talking about a 13-year-old, a 16-year-old, a 21-year-old.
Although I will tell you, after watching some film, it's remarkable how identifiable some of the aspects that you might, that people often think of regarding maybe being a hint that autism might be present in somebody. But the research is fascinating, and they also found that ABA is useful for the kids with Down syndrome, and that the families tend to identify more with the autism aspect of their son or daughter than they do with the developmental disability. So I don't know. I've got a couple of contacts.
Yeah, I would be curious.
There's a lot of research going on, and just maybe a little bit of a heads up. I could do that separately.
Sure.
Thank you. Sorry about that. Like I said, you come away, you think you know everything. And clearly I do. Are there other questions or comments at this point regarding the waiver update? Fascinating. Can't wait to hear more.
Thank you.
Thank you. Next is the budget and finance update.
Cheers up here for me.
You can choose.
Good afternoon. I have a few
first draft I saw was a little frightening. So we had Steve went to the last meeting for me because I was on vacation, but and had some conversation with them along with the other PIHPs about bringing back these protected categories and understanding really what was meant by the protected categories, making sure that everyone has enough to meet their spend down and that everyone has enough to cover their community hospital costs for general fund people. So as I understand it, they're going to go back and relook at it that way, and then so getting back to where we started. So the number that I saw was not good. I don't want to frighten anybody with it, but the hope is that they're going to go back and we're going to find a little better way to distribute GF funding. So I don't know that the last email I saw from Tom Rumlick was that they didn't really anticipate being able to do this for 10-1, so it's likely going to be pushed back a little further. But hopefully we can get to a methodology that works for everybody, because there shouldn't be anywhere that can't cover their spend on. There are places in the state that aren't even serving spend on people at this point. So certainly it's an issue that needs to be addressed. Do you have any questions on that before I move on?
Apparently. Steve and then Willie, or
Yeah.
Willie and then Steve.
Well, mine's just a
Duke
comment.
it out.
I looked it up in the glossary of acronyms. It's Institution for Mental Disease.
Yes, that's it. One of those modern names.
Yes.
Willie?
He just said it.
That's
Okay,
all.
sorry.
You're gonna supply the same information.
Is that it for questions on general fund? Moving on to, as you are all aware, we finished our financial audit back in April. We just finished the compliance audit and the single audit. So the single audit is for the federal awards to the grant contracts. No findings there, all clean. And the compliance audit is part of
past, what we've done to manage budgets is that we increase workloads on our providers and we decrease pay. That is a recipe for failure. Because what happens is you have a lot of individuals who stay in the field because they love the field. Eventually, the pay becomes so challenging to the point that they have to decide to either take care of their family or do the thing that they love to do. This will allow us to present with the state the actual cost of care, which is different from healthcare. In healthcare, they can pretty much tell you what it costs to do specific services. We know that there's issues with fee-for-service as it relates to ramping up the volume and not being able to identify the severity of care. We also know that there's problems with not to exceed as it relates to managing access and some having a higher level of service and someone else having a lower level of service. So we've asked our providers, our core providers, our direct service providers, we're actually getting an actuarial, as mentioned, from an outside source and our team to try to come up with this very important method of identifying actual costs, identifying proper reimbursement measures, regardless of what it costs. Meaning that if it's actually stated that to perform the services we're actually underpaying, it will at least give us a platform that we can present to the state and tell the state this is the actual cost of services, this is the actual cost of fair wages, and it will allow us to have a better argument in the future. So this is a very important project that we're going to undertake.
Any other questions or comments at this point? Apparently not. Thank you. This is our second opportunity for public comment. Is there anyone who would like to speak at this time? Okay, if each of you would be sure and sign in and identify yourselves before you make your comment, we'd appreciate it.
First, let me apologize for my attire. I came and promised myself I would just listen. So I apologize to everybody, but I started out with long pants, but because of all the cuts, I ended up like this. My name is Robert White, and thanks for hearing my comments. I've got a couple questions. Let's start with the most recent comment Willie you just made about being able to accurately assess what the costs to serve are. And I've had some, as a parent of two adults that receive services, I was under the impression that you've got the PCP that lists the services that they should get. And then, I said, well, there's got to be a rate structure. So you just go in and calculate that. Should be pretty easy to dollarize. And Mr. Brooks had told me and informed me at one time that that's probably oversimplified. Maybe that's the way it logically should go. But when the state might make a case to say, well, Oakland County has plenty of funding, it's just they're not spending it right. It just seemed logical to me that you would say, no, that's not the case. Look, here's the facts. So from a business standpoint, logically I felt that you had to know what your cost to serve structure was. And the fact that we're just now going back and having put together those pieces, not only to defend our community mental health funding that we get, but moving forward to say, no, this is what we need. It's a little bit counterintuitive for me because I would have thought that would already be in place. So I can't, as a parent, my sons as recipients, say enough that we've got to move on that, and I'm glad to hear we're moving on that because it's one of the only ways I think we're going to be able to make a case in front of the state that you're wrong. Here's our population. Here's what we're obligated to is, I'd like to know a little bit more about the annual funding for the Medicaid autism benefit. And it might have been shared at a previous meeting. Is it all federal? Is it some county match? Does it come from grants? But I'd really like to know what is the annual funding for that initiative, and where does it come from? And then it just seems to me that, and I know there's reasons for this. Maybe it's the relatively newness of the program. But when I think of statistics of 1 in 60 or 1 in 68 being diagnosed today, that's the frequency. It just seems like when we talk about only 60 that are participating in the program, it just seems like an awfully low number to me. I know that the experts that got up in here said it was linked to the school systems, but it just, in my mind, I'm thinking either something's wrong with my thinking or the statistic, because it seems to me we have many, many more people that would be interested in taking advantage of that benefit. It just doesn't line up to me. Right? So my question there is, if someone could get with me and further educate me on why there seems to be this dissociation, I would really appreciate it. HCBS, trying to follow it, and there's so many moving parts to it that it just is very confusing to me. One thing that I don't hear discussed in terms of report outs is the cost. I hear timelines, I hear mandates in terms of surveys, but I don't hear anybody talking about what the cost impact is and where the funding's going to come from to be compliant. And it's got to be a huge number. So again, I don't know who I'm asking the question to, but someone please get with me and help me understand what this alignment is with the ruling and compliance versus the cost to get there, because it scares the devil out of me. 2016 fiscal year budget, we've got some high-level numbers today, and I know you're giving us everything that you can give us in a timely manner. I want to make sure I heard Mr. Brooks correctly in that the $5 million that we heard today in terms of reduction, that $5 million, what I heard was that's what you're going and asking the providers to meet in terms of a reduction across all core providers. Now maybe I heard it wrong. I just want to confirm that. And that Mr. Brooks did clarify, that's really not a reduction in the budget and funding that's coming to Oakland County. It just, that is, is trying to not spend down further reserves. So it's not in fact a reduction. So it's not a question. I just want to make sure my understanding, my head is clear on that. If I misinterpreted that, please get with me. On the budget piece of it, and I know you aren't overlooking, but on January 1st, there's going to be another increase in minimum wage. That automatically hits every core provider and direct service provider. And I don't know what that impact is. From $7.40 to where it's going to be in January, I think I saw a number of 92 million across the state. But I don't hear anybody talking about, that as part of the planning process. And that's going to happen no matter if you or I are in this room in January 1st or not. And it's got to be a huge number for Oakland County. So I'm bringing it up because I don't want to see service providers go out of business and have us, be sitting in board meetings or committee of the whole meetings talking about another, let's say, judge situation, because that could be a real calamity if we're not prepared for that. The UMUR issue, and I'll combine that with bringing back in the transition of access function. I hope, and there has to be some cost modeling that someone has done to say that we're just not, I don't want to underestimate consistency of services. I don't want to underestimate conflict-free case management. I know they're important, but there has to be some modeling that someone has done to say that we're just not transferring budgets in. There's got to be otherwise we're poking a balloon and it pops out the other side. There's got to be some reduction from a core supplier standpoint. And maybe that's how they intend on meeting some of the 5 million that you're asking to meet. But if there's not a reduction someplace, and we're just transferring it in for very good reasons, but if we're not saving anything, then I really, really question, are we really digging deep enough into those initiatives and getting out of it what we need to from savings? Thank you.
It's the sign-in sheet, excuse me, Mr. White.
It's right there.
Please make sure you sign. Would you like me to get your response? Get ready.
Greg Cummins, President Alliance from Valley Hill County. I too was encouraged by all these comments that getting costs under control, understanding what the costs are. The difficulty is that there's a piece that's missing still, and that is how many people should you be serving? You're not serving them all. A lot of people aren't coming in the front door either because they're being consumed or they don't know they should. And we should be reaching people who are pre-crisis, not just people who are in crisis. But anyway, my main comment had to do with the utilization management. I'm wondering if you're not facing some unintended consequences. First of all, it wasn't clear to me how this relates to person-centered planning. It sounded a bit like our agency does person-centered planning, and then they come here and they find out that they spent too much money. Well, the problem is they're not spending enough money now. They've gone around and cut services and reduced services being provided to people, and they're not about to come back and say, no, we should spend more. They're not spending enough because they're managed care and they're trying to cut costs. Now, the theme of this is control costs. It needs to be control costs and assured quality assurance, quality care, which means you don't just control the top level, don't spend too much. You also need to control, don't spend too little. I didn't hear that. There are people out there who aren't getting the services they ought to be getting. A lot of them. So if you do this right, costs are going to go up. You may find a few where they're spending too much, but I'm sure if you look, you're going to find there's a whole lot who aren't spending enough, because that's how they save money. That's the incentive that you build into this system. So, be careful. You do need to provide that quality care. And a lot of people are not providing it now.
Thank you, Fred.
Good evening. My name is Rosemary Rangi, and I'm the mother of a 35-year-old
thank you for your thoughts, we appreciate it. Charlie?
Hello, I'm John Troney, president of AIMWA. We're a 503C organization, 503C organization, not connected with any core providers. 501.
Yeah, C3. Too many letters and numbers.
I just want to piggyback on some things that were said. It was said at the meeting that 95% of services were done by direct care workers. And statewide, they make $9.06 an hour. That's the salary. I've been told by numerous providers, service providers, residential providers, that they cannot recruit them fast enough to leave in before they can get new people in. They're saying that traditional methods, such as newspaper articles, Craigslist, is no longer working. The system's not gonna, it's in trouble because of the budget. It's collapsing because of the budget, but also because of the pay for direct care workers. The system, one provider said, I can probably cope with the budget somehow, but I can't replace the staff. We're gonna collapse because of lack of staff. So I want to mention that to you as being very important. I just want to mention a little sensitivity on your part. We're talking, we throw terminology such as consolidation, we use the word inconsistency. And I think Mr. Brooks said something to the effect that other PIHPs do consolidation, so we should do that too. Sometimes the consolidation is on the back of core providers losing staff. I know that last fiscal year they were cut 6.1%, several $1 million, and the core providers made their cuts, but they had to pass them on to service providers who made their cuts. Direct care staff lost benefits, health care, so it's a terrible situation. I also think that we use the word consolidation and inconsistency, but we're laying off people too at the core providers. We mentioned just recently today about intake at Common Ground. Those people are losing their job, but you're posting new jobs. I'd be very cautious about, using that word inconsistency. There's a reason sometimes. I don't know. It might be the reason. It may not be the reason. It's words. I don't know what they mean. Also, I'd like to make a request. The core providers have to tell Oakland County CMH, they have to be transparent. They have to give detailed information on the budget cuts. I would ask the Oakland County CMH to do the same. What was the actual cuts by Oakland County CMH in 2015? What are the projected cuts in 2016? Also, along with that, I like detail. We're cutting it, we cut ourselves $2 million. Was that staff? Was that increasing positions? I'd like to have detailed information on that, because you talk about transparency, and that's what core providers do. They give you transparency. You request of them detailed information. So I like to see that with yourself. Now, saying that, at the same time, today, you mentioned, it appears that intake is going to be a function of Oakland County CMH. Those are new positions for your organization. I'd like to know what your staffing was in 2015, 2014, and 2015, what it's projected to be in 2016. So, the only reason I'm up here is to extend, make it more sensitive to the needs of direct care staff. The co-providers who are being, not only have they been cut 6.1%, they're being cut by staff. I mean, you're cutting some of their staff now. So, having said that, thank you.
Thank you, Josh. Are there any others that would like to make public comment at this time? Make sure everybody please signs in so we can get a response to you.
If I could add one other thing, please. Rosemary and other people mentioned this. You get back to people within 30 days. That's too long for parents and stakeholders. I would suggest, somebody said do it publicly, I like that idea, but I would like to have something sooner than 30 days. It shouldn't take 30 days to get some of this information. So I just want to add that too. Thank you.
Thank you. Okay, at this point, are there any board member comments or questions?
I had a question about scheduling. Going forward, is our meeting on Monday, July 13th going to take place? Committee?
We're trying to emphasize committee of the whole versus
Okay. And then what about the 30th for study session? Is that still? Yes, I'm glad you brought that up. I wanted to ask Darlene. Darlene, you had wanted to do something I'm trying to
Oh, the recipient rights.
Right.
Yeah, I need to, the response that I got in email was that Willie did not approve that, so I still have not responded to that, but I think it's about time for us to have a recipient rights training for our board, and I know they hired a new trainer in that department. I don't know if they're ready to do it, so.
Can you let me know?
I can let you know, yes.
Because the other topic was Judith Taylor, but she's out of town on that date. So it really will be a question of whether we have the recipient rights training unless somebody else has a topic. So I will look to
Okay,
hear from you.
yeah, that's fine. I know some people are on vacation, but I can contact and find out about that and see if they're prepared to do that.
So we'll let you know as soon as we can.
Okay. Since you brought up Judith Taylor, is she going to be looked at for another session for us to provide?
I presume so. The question is her availability, and for I would leave that to a study session. I'm not sure her contract is up soon. Through September, so we have through September.
Okay.
So I'll talk to you about that.
Thank you.
I just have a quick question. The session that was scheduled with Judith kind of had two conflicting answers. I just want to be sure Judith Taylor's session on finance on the 14th is canceled. Is that correct?
That was my understanding.
I do have a topic that I'd like to talk to you and perhaps Anya about, and Willie maybe, to add to for a study session. I think it would be a very interesting business discussion if it's phrased properly, and that's why I want to get the input from all of us on this.
That would not necessarily be in July, right?
I thought you were looking for an answer for
Well, it
July
depends.
30th.
I'm not sure how long recipient rights training would take.
Well, if you go to a training, it's 3 hours, but I think they condense it for the board. I believe the last time there was a training, it was like maybe an hour and a half. That was with Kristen Malevchuk, and she did the training. Jack Johnson was there. So I'm hoping this time that it could be Vicki, mostly probably Chad, Tammy Lido could do the training. There's several staff who could do the training.
could do both, so we'll talk.
Okay.
I'm not clear, there is no meeting on July 13th then, is that correct?
Correct.
Okay, thank you. Other board member comments or questions, Darlene?
I just want clarification, is that the policy meeting that is not going to be occurring this month, or the budget and finance?
That was a drill down meeting.
Oh.
So neither will be meeting.
Correct.
Okay, so
At this
neither.
point, yeah.
Okay.
We're trying to place greater emphasis
On
on
the
topics
committee.
at committee of the whole
Right,
and the
okay.
board.
Other board member questions, comments? Okay, are there any thoughts regarding future agenda items at this point in time? I guess there have been, I guess it's going to develop.
Well, we also, in executive committee, laid out for August for this committee. So-
Yes, we did. We have a quarterly plan.
I just want to ask, I'm having a little bit of question to myself as to which kinds of items I would like to address in which group. And it's kind of, we're pushing everything for committee in the whole. But you have an item like an update from OHIM with its FQHC status. There will be an update somewhere, but I'm not sure I know when to ask for that and which group. Is there?
If you just let us know that that's a topic of interest, we can have it at the committee of the whole. The goal is to make sure that every board member is getting the same information. That's why we're de-emphasizing two different meetings. The policy versus business. So if you want a topic, that's what Judy's asking for.
And I think that now we're trying to look at it in a quarterly approach. And if we have suggestions from board members that could get incorporated into the overall plan, we're looking at all meetings at the same time to see where things work best.
But there was also a list that we had standing committee reports to committee of the whole, correct?
Yes, and many of those are, for example, at our board meeting, that you have the cooperative, we're gonna have strategic planning. So we're trying to incorporate those various topics into these meetings. So it's all.
It could be either or, it could be a board meeting. or
Absolutely.
something.
One reason I'm trying, we have a larger audience at board, and I think it's important that they hear our topics and our discussion.
Sid?
Well, I think that, if I can just embellish a little bit on that, I think the general consensus was that we were going to kind of alternate the chair position for the committee of the whole meetings. And for the committee of the whole meetings, we were going to address issues that board members would like to bring up as relating to business topics, and with Judy, policy. And we're going to see how that went. I think it'll be very informative because the other general consensus was there were a lot of business topics that I had planned that were very interesting, and many of the board members wanted to hear more about it. So we thought that that would probably be the best time, as opposed to having staff duplicate a lot of time and their efforts in coming up with a program. And we'll see how that works. But I do have a list of what I think will be very interesting topics for all the board members to hear. But it primarily relates to the business operations of CMH.